Hello. Now this lab covers both blood and the heart. So this will be exercises 20 and 21. You will have worksheets handed in for both 20 and for 21. For you to successfully complete all the operations, I will make note also that there are some lab videos you should absolutely have to view. These will help in your understanding of the content as well as successfully completing the exercises. Let's move forward. Now, the objectives are to review the blood and blood cells as well as perform the blood typing experiment. Just note that there's no blood typing experiment you are going to do for hands-on. There is a video for blood typing, and I want you to be able to review it. You will review the structure and function of the heart. Now, as for completing the dissection of a sheep heart, instead you will have a calf heart, and this will be demonstrated by a series of videos. All the videos that you need to do for the heart, both using a heart model and the actual viewing of the dissection of the heart, will be labeled lab number 2, and then there'll be lab number 2, heart 2, 3, etc. There are 5 of them that you need to view. You will also review the microscopic slides of blood and heart. You'll see those in this slide, video, as well as in your lab exercise book. You will need to complete the worksheets, which is 369, 370, as well as 389 to 391. You will need to turn these sheets in by Friday, 5 p.m., okay? They are attached into the content section for this lab objective. Now, blood is composed of blood cells, which are the red and white cells, blood fragments, which are platelets. These are all suspended in a fluid matrix. Red blood cells, the erythrocytes, have no nucleus, yet they make up about 99.9% of the formed elements. Their function is primarily oxygen carriers. They do also have the capability to carry away carbon dioxide. Basically, red blood cells are filled with hemoglobin. They have a biconcave round cell appearance. White blood cells, leukocytes, are nucleated. They are larger than erythrocytes and they function immune defense. Now keep in mind the difference here, which has a nucleus, which does not. Why? Because without a nucleus, you do not have the necessary genetic information in the form of DNA to make replacement components for the red blood cells. That's why their lifespan is about 120 days, and they're just replaced by new red blood cells, as opposed to them being able to repair themselves and continue their function. Platelets are really cell fragments. They have no nucleus, and they're smaller than erythrocytes. In essence, some people would refer to them as just bags of clotting medium. When we talk about hematocrit, this is the value that indicates the percentage of whole blood composed of cells, that is, formed elements. Normally, the indicator of red blood cells, and it's also related to the oxygen carrying capacity. When you talk about normal levels of hematocrit, it ranges from 42 to 52 for men and 37 to 47 for women. As you can see in this diagram here, we have whole blood. When we start beginning to separate it down, 55% of it, and the range does vary, 46 to 63, consists of plasma, which will include plasma proteins, albumins, globulins, fibrinogen, enzymes, hormones. Also, we want to include things like antibodies. Other solutes, which would be electrolytes, organic nutrients, waste, as well as water. 92% of plasma is water. The formed elements, which average out about 45%, we talked about some of the ranges, will include platelets, white blood cells, which include neutrophils, eosinophils, basophils, lymphocytes, monocytes, as well as red blood cells. Now, hemoglobin, HB concentration in in red blood cell. This is measured in grams per deciliter, and the normal range is from 14 to 18 for men, 12 to 16 for women. Now, you might wonder, well, why is there such a difference with the men and the women and it's basically testosterone. That enhances the cellular demands and the cellular bulking up as part of a secondary sex characteristic, and therefore you're going to have a greater amount of red blood cells necessary to sustain the larger bulk mass of tissue, particularly in skeletal muscle tissue. Now, anemia is a condition characterized by the reduction in oxygen carrying capacity and a resulting decline in oxygen transport to the cells and tissues. Lower than normal hematocrit or HB concentration is an interesting or a very critical warning sign. Hemoglobin is an oxygen where oxygen binds to iron in the heme group. Interestingly enough, carbon dioxide will bind to the protein chains of the hemoglobin. And further, you want to keep in mind this: carbon monoxide has a stronger affinity to the iron heme than oxygen, about 200 times greater. That's why when someone has carbon monoxide poisoning, they're usually put into a hyperbaric chamber, which has a much greater amount of oxygen, and so that will help push off the carbon monoxide and free up the hemoglobin binding sites for oxygen. Here is a typical smear of peripheral blood. You see the great abundance of red blood cells. You see some of the smaller platelets. You also have a few of the white blood cells, basophils, neutrophils, lymphocyte, eosinophils, as well as monocytes. When you take a note of the structure, you can see this in a colorized scanning electron micrograph. You have basically a diameter of about 7.2 to 8.4 microns for this round biconcave shaped cell of an erythrocyte. When we go into the erythrocyte and begin to look at the hemoglobin, remember that hemoglobin is made up of 2 alpha chains and 2 beta chains. In each one of these chains, there is a heme group, which has at its very center iron. This is a porphyrin group that exists to hold the iron. When we talk about identifying white blood cells can be divided into 2 groups, granulocytes and agranulocytes. Granulocytes have distinct granules in cell cytoplasm. They include neutrophils, eosinophils, and basophils. Neutrophils are the most abundant white blood cell that you're going to see. They have multi-lobed nucleus, so it's not nice round, but it's kind of like it's been pinched around a little bit. They act as phagocytes by engulfing and destroying pathogens and release cytotoxic enzymes. Eosinophils, their cytoplasm is filled with a red or orangish granules. This depends on this right eosin stain. Right stain has also been referred to. Eosinophils are also multi-lobed for nuclei. They diminish the effects of allergies, inflammation by releasing antihistamines. Their numbers will also increase upon the presence of parasitic worms. So usually if you have an elevated eosinophil count, the first thing the physicians will start to ask is, does this person have parasitic worms? Basophils are bilobed nuclei with dark blue or purple cytoplasmic granules. They enhance inflammation and tissue repair by releasing heparin and histamine. Now, let's talk about agranulocytes. They lack the granules in the cell cytoplasm, and they include monocytes and lymphocytes. Monocytes are the largest white blood cell. The cells differentiate into macrophages. They will attack and destroy bacteria by phagocytosis. Lymphocytes have a very narrow rim of cytoplasm. They are common to be viewed in a blood smear. They will regulate immune response by attacking cells directly or producing antibodies. This is where we get into lymphocytes being either T cells or B cells, etc. You want to be mindful of that. So here again is our smear. Notice the huge nucleus, very thin border of cytoplasm here, whereas you have a much larger cytoplasm here, 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 and here. And notice that instead of a nice round nucleus, eosinophils will have this bilobed structure. This is multilobed. This is also somewhat almost like kidney-shaped. Same thing here. This is where we get into one of the clinical lab tests. It's performing differential white blood cell count. Now, under normal conditions, blood contains a certain percentage of white cell types. Under abnormal conditions, there can be indications of deviations of white blood cell counts, which will indicate things like bacteria, viral, or parasitic infection. A differential white blood cell count is a laboratory test that determines the percentage of each white blood cell type. I encourage you to go over to page 365 in your lab exercise book and review scanning and counting protocols. Now, if someone has leukemia, they have a blood cancer that involves uncontrolled propagation of abnormal white blood cells in the bone. Several things to keep in mind. They're abnormal not merely in the sense that their numbers have increased tremendously, but they're frankly very useless as white blood cells. Leukemias can be classified according to the white blood cell involved. Myeloid leukemias involve granulocytes. Lymphoid leukemias involve lymphocytes. This would be the approach that one would do with a lab, with a blood smear, and you would scan it to count and get various information, such as the differential white blood cell count. Notice this scan across the surface, drop down a bit, scan back, drop down a bit, and scan. That is basically how this is done, although it can be done not merely by just hand and by a lab technician, but it can be done now in certain cell analytical equipment where they do it automatically and with a computer to analyze and differentiate between what type of blood cells, etc. So it's just a matter of making the blood smear, putting the slide into the automated reader, and then getting a computerized printout afterwards. Now, determining blood cell type or blood type. In the lab, if we were going to do it in the lab, we would be using artificial blood kit. Let me give you as much of the relevant information that you need to understand about what happens with a real blood typing process. Keep in mind that blood type is a genetically determined trait. Typing is based on the glycoproteins, that is the surface antigens or agglutinogens, present on the surface membranes, the cell surface membranes of the red blood cells. Normal immune systems recognize the surface antigens as self, and therefore will not attack them. So what I mean by not attack them is, if you have type blood A, if your blood type is A, you will not have anti-A antigens or antibodies against that blood type. Same thing if you were blood type B. You would not have anti-B antibodies because that would be an autoimmune disorder. But if you have type A, you could conceivably have anti-B antibodies present. And vice versa. If you are type B, you could have anti-A antibodies. Now, what if you have type AB? If you have type AB, you are neither going to have anti-A antibodies nor anti-B antibodies. Okay? Now, the blood plasma will contain the antibodies or agglutinins, which are genetically programmed to attack the surface antigen if present. If incompatible types of blood are mixed, the antigen-antibody reaction will occur, and this will result in agglutination, that is, a clumping up of blood cells. And this can be disastrous for a patient. It can cause these clumps to form clots in organs such as the kidney or the liver or even in the brain. So that's why you have to be very careful for having compatible types of blood where you're giving blood from the outside to a donor. Now, the two primary blood groups that cause significant antigenic reactions are the ABO blood type system. Now, type O is the universal donor. Type AB is the universal recipient. So you can give type A or type B blood to an AB person, no problem. You can give type O because it has neither an A or a B antigen. All right? Now with rhesus, the RH factor, that's where we get, when we talk about A positive or B positive or A negative or B negative, the negative or the positive refers to the presence or absence of the RH factor. Therefore, if someone is Rh positive, they have the Rh factor. If they are negative, they lack the Rh factor. Now, as I mentioned to you before, the basics here of the ABO, I've just gone over it. Type O will have both anti-A and anti-B. Type AB will have neither. The rhesus is a little bit different. Here's what's going on. You have to understand that with a rhesus factor, if let's say you're Rh negative, you don't have anti-Rh positive antibodies immediately. Rather, you have to be exposed to Rh plus blood. Okay? This is where you get into unique situations where you have a mistyping, and once you have the mistyping, the individual will start to generate anti-Rh antibodies. They don't just make them on their own. And when we do a blood typing, we would test for anti-A, anti-B, and anti-Rh serum in the antibodies. We will also do agglutination tests, and if they are positive for a specific blood type. What do I mean by this? You'll see this in a second. I've mentioned the universal donor and the universal recipient. You need to know those. You will want to review the steps to conduct a blood type test. And as I mentioned before, if we did this in the lab, we would not be using actual blood serum due to the biohazard risk of bloodborne diseases, etc. And we use certain reagents. Here is a diagram. And a lot of times when you're talking about anti-B antibodies, they're not going to be in merely the IgG format in the sense of just two. They're actually in IgM formats, as you can see here, here. AB will have neither, and type O could conceivably have anti-A, anti-B. Now, here's where you get the clumping versus no clumping. If you had added the anti-A antibodies, the person is type A, what's going to happen is the antibodies start binding to the neighboring red blood cells, forming kind of a clump or a clot. If you have anti-B antibodies, well, there's no B antigen present, so it's just going to be sort of this solution here. Now, that means that type A plus can receive A plus blood, O plus blood, or O negative blood. And we can go down and use this for the B plus or the AB. Now, here's the trick with AB. If you get clumping with both anti-A antibodies and anti-B, that is the verification that you have AB. You've got on the blood cells both the A antigen and the B antigen. Now, because this is also positive for RH, you're going to get also clumping on the RH test. Now, what happens if I have O negative? As you can see here, no clumping, no clumping, no clumping. This tells you that it's not A antigen, not B antigen, and not RH. So it's got to be O negative. Now, we're going to move from here to the heart. I want to give you a caveat here. After you were done going through the PowerPoint, you need to view some of the videos because the videos are going to review a model of the heart, the circulatory system and the structure, as well as do a quick and very detailed analysis of a calf heart. In lab, you would have done a sheep heart. The instructor shows a calf heart, and it's great. Now, examining the organization of the heart. The heart is enclosed by a serous membrane sac called the pericardium. The sac is composed of two layers, the fibrous pericardium, which is a tough connective tissue layer, the serous pericardium, which is a delicate layer that surrounds the heart and forms a double layer sac around the heart. In this pericardium, you have the serous layer composed of the visceral pericardium. This is the layer in contact with the heart wall. The parietal is the outer flexible layer, and there is a cavity there that is filled with fluid, pericardial serous fluid. Pericarditis is an inflammation of the pericardial membranes, and it can lead to the overproduction of fluid in the pericardial sac. This tends to restrict the heart movement as it is expanding, contracting, expanding, contracting. Therefore, you get a condition called cardiac tamponade. This is where the normal movements of the heart are impeded by the buildup of fluid in the pericardial cavity. Now, pericardiocentesis is a procedure where doctors will use a needle. They will put it into that cavity and begin to remove the excessive fluid from the pericardial sac. Here is the various linings here. Here's where the pericardial fluid would be. You have the parietal layer of the serous pericardium, consisting of areolar tissue and mesothelium. You have the apex of the heart, and this is a fibrous attachment to both the sternum and of the diaphragm. Okay, and so you can see the different layers here. It's extremely important to get this concept down. Now, when you examine the external anatomy of the heart, you will deal with where it's located, which is the mediastinum, which is a centrally located area of the thoracic cavity, which occupies the heart. 2/3 of the heart is positioned to the left of the midline. Okay, the heart is divided into two atrium, which are superior and receive the blood, and two ventricles, which are inferior and discharge the blood. You need to be able to locate the following, either by diagram or by model. The apex of the heart formed from the inferior tip of the left ventricle, the right atrium, the right ventricle, the left ventricle, the left atrium. Now, the coronary sulcus divides the atria superiorly from the ventricles inferiorly. The anterior interventricular sulcus forms the border between the left and the right ventricles. Here is the heart. Here is where it's located. Notice that if we were to draw a line right through this middle, there's kind of an angle where it shifts over to the left here. This is kind of called this cardiac corner here, where basically what you have is an indentation on the left lung because the space is taken up by the heart. All right? When you look at the heart, you will notice a variety of veins and arteries. You need to be aware of the superior vena cava taking blood from the upper part of the body, bringing it down, the ascending aorta, which sends out blood after it's been oxygenated, the pulmonary trunk, the base of the heart, the posterior interventricular sulcus, the aortic arch, which passes posteriorly over the pulmonary trunk, the left and right pulmonary arteries, which are branches of the pulmonary trunk, the pulmonary veins, two of which are on each side, and they enter the left atrium. The superior and inferior vena cava, which enter the right atrium. This is the ligamentum arteriosum. This is formerly what was a bypass in fetal development for blood, so that you had blood that was coming in, would mix in and be distributed. What happens is after birth, this closes up and fibrosizes, so that's a remnant. You have the ascending aorta, and you notice the aortic arch where you have the major arteries heading out to the limbs as well as to the head for circulation. You have the right atrium, you would have the left atrium, you have the right ventricle, the left ventricle, you have the anterior interventricular sulcus, you have basically the superior vena cava, bringing in from the superior part of the body venous blood. On the back of it, you'll see in a second the inferior vena cava, which is right here. So they meet together and blood enters into the right atrium. It will then be pushed down into the right ventricle and sent out by the left and right pulmonary arteries. Now notice the colorations are different. You need to keep in mind something. Systemic oxygenated blood will appear red, and therefore the blood vessels will appear red. Systemic deoxygenated blood will appear kind of bluish. This is just for diagrammatic and educational information. And therefore it's going to appear blue, the veins will appear blue, etc. But it's reversed when you get into pulmonary circulatory tree, because what happens now is your arteries are taking deoxygenated blood for gas exchange at the lungs. Therefore, the arteries leaving the heart going to the lungs will be somewhat bluish. The veins returning the oxygenated blood from the lungs will appear reddish. Okay? And here you have the blood coming in from the superior and inferior areas of the pulmonary circulatory tree, entering the left atrium, passing down to the right, to the left ventricle, and then being sent out by the aorta. Examining the inner anatomy of the heart, this is where we're going to get into the heart chambers, etc. You have a left and right atrium. You have a fossa ovalis, which is formerly a bypass during fetal development, and can lead to an atrial septal defect at birth, which can be taken care of. Usually what happens is it closes and within a short period of time fibrillizes and closes off, so there's no mixing of deoxygenated and oxygenated blood. We have the pectinate muscles, the superior and inferior vena cava, the right atrioventricular orifice flow, which leads to the right ventricle. The openings to the pulmonary veins include the left atrioventricular orifice, the left and right ventricles. No, I stand corrected there. There are openings for the pulmonary veins. We'll get into that in a little bit. The trabeculae carni, which is a regular network of muscular elevations of the ventricles. The conus arteriosus, the wall is smooth, it leads to the pulmonary trunk. The aortic vestibule, which is smooth walled and leads to the aorta. The interventricular septum is thicker than the interatrial septum and separates the ventricles. As you can see here, here is the interventricular septum. This begins to narrow down, becomes basically what you would have the separation for the right and the left atria. Blood comes in from the superior vena cava, comes up from the inferior vena cava, enters here, the right atrium. You'll notice the fossa ovalis here. You have some of the pectinate muscles here, but much more of them down in these much tougher and much more thicker walls of the ventricles, which are going to be pushing blood out of the heart. Okay? The blood comes through. You also have an opening of the coronary sinus right here. The blood will pass through the valve, tricuspid valve, otherwise known as right atrioventricular valve. Here, these valves are kept open by the chordae tendineae structures here, and they're also accompanied by their proper position and strength of opening and closing by the papillary muscles. The pulmonary valve is right up here, so the flow of blood enters here, goes up through here, and then leaves for the pulmonary trunk to the left atria, and on this side would be the right, not the left atrium, excuse me. It would be in the flow going to the left lung and to the right lung. Now, upon return, the left pulmonary veins are going to bring the blood in. The right ones will do the same, and we enter the left atrium. This will pass through the mitral valve, also known as the bicuspid valve or the left atrioventricular valve. You will have again chordae tendineae. You will have again papillary muscles providing stability. And then you enter the left ventricle. Notice that the wall of the left ventricle here is much thicker than what you have on the right. That's because now you've got to create a greater amount of force as you expel the blood, because it's going to go through the entire systemic circulation. Okay? Now, blood goes up through here, There is a valve over here, which we would have the aortic valve. It's a little bit difficult to see. This is also known as the aortic semilunar valve. Passes up through the aortic arch. Blood is distributed superiorly through these branches here, and then it will go downward, as you can see here, the descending aorta. When you examine the internal anatomy of the heart, we have to, of course, recognize the heart valves. Semilunar valves, 3 cusps, regulate the flow of blood between ventricles and the great arteries. The pulmonary semilunar valve contains cusps that are extensions of the pulmonary trunk wall. The aortic semilunar valve, similar to the pulmonary semilunar valve. The atrioventricular valves, AV valves, are positioned between the atria and the ventricles at the atrioventricular orifices. The right AV valve, otherwise known as tricuspid valve, has 3 cusps. The left bicuspid or mitral valve has 2 cusps. The cusps are extensions, as I said, of the ventricular chambers. The chordae tendineae are these fibrous cords that connect free margins of the cusp to the papillary muscles. Now, the papillary muscles are located in the ventricular walls. When one has an infection known as endocarditis, which is an inflammation of the endocardium, the infection of the heart's inner lining usually involves the heart valves. Large clumps of bacteria or cells, otherwise known as vegetations of cells, are attached to the heart valve and impede its normal function. So, here we have the pulmonary veins, the delivery into the left atrium, the passing through the mitral AV valve. The left ventricle is dilated. Chordae tendineae are loose. The papillary muscles are relaxed. You have a flow of oxygenated blood here, and we notice that the aortic valve is closed. The pressure has to develop sufficient so that it will push this open and the flow of blood will go through. As this pressure is building up, these muscles will eventually contract to force as much blood through in that single stroking motion. As you can see here, the aortic valve is popped open, and we have much less volume here as we're controlling the space. Also note this, that the chordae tendineae here become tense, the papillary muscle is contracted. The pressure which built up behind these valves closed them so that you do not have a backflow, which is not what you want. Here you have ventricular contraction. Now, examining the internal anatomy of the heart wall. There are 3 tissue layers: the endocardium, the myocardium, the epicardium. In the endocardium, this is thin serous membrane of connective tissue and simple squamous epithelium. It makes up the internal walls of the heart chamber. The myocardium is the thickest layer, composed of cardiac muscle cells, and they're separated by connective tissue containing capillaries and nerves. The epicardium is the outermost layer. It's a serous membrane of connective tissue and simple squamous epithelium. And this would be referred to also as the visceral pericardium. And here you see this, okay? So you have the pericardium, you have the parietal layer here, which consists of dense fibrous tissue, areolar tissue, the mesothelium. The visceral layer here is composed of a mesothelium here and areolar tissue. Here you have connective tissue spaced in between all of the myocardial cells. You also have this space here which contains pericardial fluid. The endocardium is consisting of endothelial cells, which actually face the blood, and areolar tissue right underneath it. Examining the blood vessels of the coronary circulation. On the anterior view, we're going to see the right and left coronary arteries. They branch off, the ascending aorta, deliver blood to all regions of the heart. The right coronary artery travels to the right along the coronary sulcus. The right marginal artery is a branch of the right coronary artery. descends along the lateral margin of the right ventricle. The left coronary artery branches off the ascending aorta, just superior to the aortic semilunar valve, and passes along the coronary sulcus, posterior to the pulmonary trunk. We have also two branches. The circumflex artery travels along the coronary sulcus, curves around the left side, continues to the posterior surface. Now the anterior interventricular artery descends toward the apex along the anterior interventricular sulcus. On the posterior view, you will see the left marginal artery. It branches off of the circumflex artery, descends along the posterolateral wall of the left ventricle. The posterior interventricular artery branches off the right coronary artery, descends along the posterior interventricular sulcus. We have this other concept called anastomosis. Singular is anastomosis. These are natural connections between two blood vessels in the coronary circulation. You'll see some connections of that in a bit. Now, with the anterior view, as we're going to look at the coronary circulation, we've got to be mindful of the venous circulation. Now, most veins drain into the cardiac sinus. It's a large dilated sac that empties into the right atrium. The great cardiac vein ascends along the anterior interventricular sulcus, along the anterior interventricular artery, drains into the coronary sinus. Everything's draining in, so just keep this in mind. Small cardiac vein travels alongside the right marginal artery toward the coronary sulcus, drains into the coronary sinus. The anterior cardiac veins, small veins, travel a short distance along the anterior surface of the right ventricle, drain into the right atrium. Now, what about the posterior surface view? Let's take a look at that for a second. The posterior cardiac vein travels with the left marginal artery along the left ventricular wall. The middle cardiac vein ascends along the posterior interventricular sulcus, traveling with the posterior interventricular artery. It's not uncommon to see both of these running almost next to each other. Here we see a couple of very important structures. Left coronary artery coming out from, if you notice here, the aortic arch. So blood supply will go posteriorly using the anterior interventricular artery. You have the circumflex artery here. You have also the right coronary artery. And then from it, you have these smaller branches called marginal arteries. You will notice that the arterial anastomosis between the anterior and the posterior, right around in here, interventricular arteries exist. If you look here, we're going to start looking at the venous supply. First off, we have the anterior cardiac veins, and we have the great cardiac vein here. This is the anterior view. Notice how you have the cardiac vein along with the cardiac artery. Now we look at the posterior view here, and here's where we get into this great collection that occurs at the coronary sinus, and it's going to empty right into the right atrium, not the left atrium. The left atrium is going to deliver some of that blood that is going to be necessary for the arterial supply because it's oxygenated blood. But you will notice several other things. The posterior vein of the left ventricle, okay? Here we have the right ventricle, left ventricle, and we have the small cardiac vein along here, as well as the middle cardiac vein there. Now, if we trace blood flow through the heart chambers, the pulmonary circulation, we have deoxygenated blood going for gas exchange in the lungs and returns oxygenated. It's a lower pressure circuit. Some of this I mentioned earlier. The right atrium, you have the blood flow going from right atrium, tricuspid valve, right ventricle, pulmonary semilunar valve, pulmonary arteries, lungs, pulmonary veins, heart. The systemic circulation is oxygenated blood goes to the systemic circulation throughout the body. Gas exchange in the tissues returns to the heart deoxygenated. The left atrium, you have from starting in the left atrium, you have bicuspid valve, left ventricle, aortic semilunar valve, aorta, aortic branches, head, neck, and upper limbs. The descending aorta supplies the thorax, abdomen, pelvis, and lower limbs. Return is via superior and inferior vena cava of the heart. And we've mentioned this before, okay? So you can see where the blood is coming back deoxygenated and where it passes through to the pulmonary circuit, which is much lower pressure, than the systemic circuit. On the surface of the heart, you have to identify the position of the heart. Now, here is a couple of things. You need to do this on yourself. Why? Rather than have somebody very uncomfortable by having somebody else put their hands on them, I decided to basically just go through this and mention it. You will take a look in the lab exercise book for this particular exercise. Locate the jugular notch, sternal angle. Notice that you will be able to locate certain information by the second costal cartilage or the second rib, the base of the heart, the left border of the heart, the apex of the heart, the internal border of the heart, and the right border of the heart, as you can see here. Again, this is something that you do to yourself to do locations of certain structures. You will note that instead of a sheep, as I said, the videos will be using a calf heart. And basically what you want to be able to do, if they can, is notice for the following structures: the pericardial sac, fibrous and parietal pericardium, the visceral pericardium, the aorta, the pulmonary trunk, right and left ventricle, apex of the heart, right and left atrium, coronary sulcus, and interior interventricular sulcus. Keep in mind, look at the difference between left and right ventricle thickness, that muscle thickness, okay? The posterior view, you might be able to notice the pulmonary trunk aorta, openings for the pulmonary veins and superior vena cava, as well as inferior vena cava, right and left atrium, right and left ventricle, as well as the posterior interventricular sulcus. This is a possibility, but not a guarantee. Here you see with the sheep, it's going to be similar with the steer, with the calf. The big thing that you're going to note is that because of the buildup of some fat, it's always going to appear somewhat whitish. And you can see the normal structures that exist here, here, and here. Now, in the dissection of the heart, pay special attention to see if you can locate right and left atrium, atrioventricular valve, the bicuspid valve, the tricuspid valve. Observe to try to locate the chordae tendineae, the papillary muscles, the aortic semilunar valve, the pulmonary semilunar valve, the trabeculae carneae, the layers of the myocardium, endocardium, myocardium, epicardium. And you can see some of this in this diagram also. You can see where the chordae tendineae are, bicuspid valve, left atrium, left ventricle. Notice the thickness of this wall of ventricle as compared to the right ventricle, okay? Here you will see right atrium, tricuspid valve, and the chordae tendineae, as well as, of course, the apex of the heart. Now, when we finish up, there are some modifications from these notes I want you to review. First off, review blood and blood cells, as well as what will be seen in a blood typing experiment that is a video that's been demonstrated. Second, review the structure and function of the heart. Complete the review of the videos for the calf heart and locate all external, internal structures that the instructor shows you. For any microscopic slide images of blood and heart, I refer you back to the lab exercise manual. Now, in this assignment, you will have to complete worksheets 369 to 370 and 389 to 391. There should not be a lot of problem here because these are all been put into a format. Now, if you need to, you may not be able to colorize them. There are some instructions on alternatives to colorizing any diagrams or charts. You can, if you want to try to colorize, you can print it, fill out all the information, colorize it, and then take a photo or scan it and make it into a PDF. But these have to be uploaded by Friday, 5 p.m. Okay? And have a wonderful day.